Hello, everyone. I see people are joining us slowly. Unfortunately, our speaker hasn't arrived, but if you bear with me, I'll be with you shortly. Let me just try and contact him. Okay, welcome. Tom Boyles. Okay, I'm going to begin nonetheless. I think our panelist, Dr. Boyles, has somehow not been around, not around. So I'm going to start by just trying to get a sense of what's going on the ground in terms of what people are experiencing in terms of difficulties with PPE. Tom. Sorry, Tom has joined us. So, Tom, do you want to just start your video? Hi, Tom.
Morning.
I think you need to unmute yourself. The volume's a little bit challenged.
Are you muted?
Still can't hear you, Tom.
I can't hear you.
Tom, also, if you take your camera, your computer, just see if you can get the light shining on your face so that we can see you better. And that light behind you is disturbing. So if you shift it slightly, we'll be able to see you better. Are you battling, Tom? That's better.
I've got my speakers on.
The volume, I think,
I can't hear anything.
Seems to be that you are. It's. Can you hear me, Tom? Can you speak now, Tom? Right, Tom? Don't worry. Can you hear me? Hello, Mimi. Do you want to speak?
Yeah, I just want to say I can hear both of you. I can hear you and I can hear Tom. So if you can't hear each other, there must be a problem between the two of you.
All right, Tom, just go ahead. I'm just wondering where. Tom, can you hear me? Just speak a little bit. Tom? Is he not hearing me? Let me just see if I can mute and unmute him. Tom, let me just send a message quickly.
I'm going to try dialing in on my phone.
No, Tom,
makes a difference.
I can hear you.
I can't hear anything.
Right. Go ahead.
I can't hear anything.
Don't worry. Look at the chat. Tom, chat.
I'm trying on my phone. Right. I can hear you on my phone.
Tom, I suggest you don't worry about the phone because it's echoing. Just speak, we can hear you.
Okay, but I couldn't hear you.
Okay, all you do is just keep an eye on the chat. If you can just, if you scroll over your screen, you'll see the chat, and then I'll keep you informed as to what's going on, and I'm sure you'll see what's going on. All right?
Sure.
So we all can hear you.
I don't know what the echo is. It's not me.
Yeah, what you do is switch off the phone, and we all can hear you fine.
Right. My computer's off, so there's nothing happening. That's not possible.
Tom, okay, go ahead, Tom. I think the phone is going to be a problem. I suggest that you use the video, which is fine. I mean, the computer, which is fine. We heard you.
You heard me, okay. I just couldn't hear you. That's the problem.
Yeah, you can't hear us, but we can hear you.
Yeah, I'll go back to the computer.
Okay. So if you switch off the other one, then we'll be fine. So switch off your computer or get out of Zoom on your computer.
Yeah, I'm out of Zoom on the computer.
Right. Phone might be challenged.
I don't know what the echo is, but I think it's from me because
it's because you come in. So just come out of the one.
My computer is off. My computer's not on. Oh, so maybe
you're on your computer. We are seeing you on your computer.
No, you're not. You're seeing me on my phone.
You've got two.
But I can see myself twice, which I don't understand.
That's right. You've got your computer still on. So you need to switch Zoom off or your browser off.
Okay.
There, well, it's still on in browser.
Oh, I see. All right. I'm sorry. Got you. Okay.
Now
that's better. I left the meeting on the phone, on the thing, because I couldn't hear you on my computer for some reason. I switched it off.
Okay. Well, we can hear you now, and you can hear us. So we're ready to go. We've got about 49 participants, attendees. So thank you very much, Tom. I think that we've sent out the invite and the information that you are a infectious disease specialist at Helen Joseph. And great background. We really appreciate that you're coming and that you're interested in helping the Johannesburg Health District to improve its approach to the COVID virus. Specifically, we asked you to talk about PPE today. I think it's on top of everybody's mind. How do we deal with it? And especially in the sort of South African context, perhaps, of where we have challenges at primary care, where managers are just frustrated they cannot get enough PPE. So your thoughts would be greatly appreciated. I'd also ask that as we're going along, that people use the Q&A to put out questions. And I think in just quick ways, we'd like to see who you are. So if you don't mind just putting out where you're from, and I'll just put this up in two minutes. So if you can do that, but while you're doing that, perhaps you can start. Tom, introducing yourself and then proceeding.
Sure. Okay. Okay, so you can hear me. So, morning, everyone. I'm Tom Boyles, Dr. Tom Boyles. I'm an infectious disease specialist. I trained largely in Cape Town, and I've been in Johannesburg for a while, 3 years or so. And this problem isn't so much an infectious disease problem. It's really a public health problem. And I think my experience that's relevant really to the COVID problem is that I was in Sierra Leone for 3 months in 2014 to 15 during the Ebola outbreak, and was involved in setting up and running a number of units, both in hospitals and outside, in primary healthcare clinics, and trying to keep everybody safe. And that's really what it's about. The number one priority is obviously keeping staff safe, and then keeping patients safe. So in terms of PPE, I've got it's quite complicated. It's been made quite complicated. I have in front of me, if I could get my computer to work, I could have shared the screen with you, but I have the COVID-19 infection prevention control guidelines for South Africa, first draft. And now I don't know if it's officially published, but I'm happy to share it with you, so you can all read it. And it's already signed by, it's not quite signed actually, by Dr. Pillay, acting DG. And it's kind of quite complicated, but everything's in there. Includes what PPE to wear, how to put it on, how to take it off, what cleaning to do in between. And the bottom line is that if you are within a meter of a patient, or touching a patient, or you're in contact with a patient, then you should wear a surgical mask. The guidance varies on a visor. That's not the most important thing, but the guidance says a visor, an apron or a gown, and a pair of non-sterile gloves. And there are videos on how to put that on and how to put that off, take that off, which again I can show you is actually a link from this document. If you've got this document, you can link through to that. If you are performing an aerosol generating procedure, which in primary care would be taking a nasal pharyngeal or oropharyngeal swab for COVID, then you should wear an N95 mask, with a visor, definitely with a visor, and an apron, or ideally a gown, and a pair of non-sterile gloves. That's the basics. The suggestions for people who are not directly looking after patients. So, for example, admin staff who might get within a meter, is generally to wear a surgical mask only. If you get within a meter of people, that's the sort of general advice. For perhaps a security guard, or somebody who doesn't touch the patient in any way, but might come within a meter of them. So, like I say, there's lots of details to this, which I'm not going to just read the document to you. That would, you can read the document yourself. I can send it to you. So, if you want to go to some questions, and then we can talk about some of the details.
All right. I don't see any people putting on questions. Do you want to perhaps go through it briefly? Or do you think that would be useful? I think that people understand that.
I've got the document in front of me. I can go through it. Briefly.
Yep.
So it begins by explaining what the different types of transmission, the difference between droplet transmission and airborne transmission, and explains that airborne transmission is when you have infectious nuclei that hang in the air for multiple hours, at a height that you can breathe it in, so 1 to 3 meters, and that's things like TB. It also includes viruses like measles and chickenpox, but that's not thought to be a mode of transmission for COVID, or influenza, or other coronaviruses. Hello. So now this is a little bit contentious, but this is the current thinking on coronavirus, is that somebody can cough out a large or a small droplet, and the furthest it can reach is about 2 meters, by which time it's hit the floor. So if you are standing up and 1.5 meters away, the droplets cannot reach your nose, mouth, eyes, which is where they come in. So if you're more than 2 meters away, you're basically safe. If you're closer than that, the suggestion is that a surgical mask is a good idea, because somebody could cough, and a surgical mask is thought to be enough to catch these droplets, which are quite large, relatively large. This is different from airborne, like normal TB precautions, where the nuclei are very, very small, which is how they hang in the air. And because they're so small, you need a N95 mask. So that's the thinking behind this. The thinking behind when you're doing a swab is that a swab is called an aerosol generating procedure. So you do actually produce very fine, small droplets when you're doing that, and therefore an N95 mask is necessary. That's the sort of dogma behind it. There's some sort of debate about this, but most people are pretty confident that that's the case. So I've got a question which popped up and then went away again. Where chats, hang on, I'm just trying to do this on my phone. You can all hear me, lots of interference, so I turned it off. Do you think gloves are essential if not physically touching the patient in primary care? We're all wearing surgical masks, but not clear on use of gloves in addition to frequent hand hygiene. That's from Claire. I agree with you, Claire. Gloves are, a debatable, are a debatable thing, because skin is a good protector, and gloves are harder to clean. So if you're not touching patients, and then you're touching surfaces, are you going to change your gloves every time you touch a surface? Because gloves are harder to clean than hands. It seems much more sensible, if you're only touching surfaces, to not wear gloves and clean your hands. So if you're not touching patients, I don't think there's anything in the guidance saying that you need to wear gloves. So sitting behind a desk talking to a patient doesn't require gloves, and I think that's clear in this document. If I go to the very bottom, I'm just scrolling through myself. Let me see if I can see an example of where that's given. Providing direct care, but it doesn't actually say indirect care, but it implies indirect care, that a surgical mask is enough. So yeah, I think that's fair.
Why don't we take questions a little bit later, once you think you've gone through the document?
Sure. Okay.
Does that work?
Okay.
I think that I've told people please to put their questions in Q&A. I'm not sure that you see popping up on your screen, but as soon as you're done, we can go through them and just see which ones you can respond to.
Sure.
Great.
Okay, so the bottom line is that I think we've got that point across, that in terms of masks, so you shouldn't be seeing people walking around your facility with an N95 mask on, unless obviously there's a TB risk. So we still have other risks. So N95 masks are only for TB risk, which they would normally wearing, or if you're actually taking the swabs. Otherwise, you shouldn't be seeing anyone walking around with an N95 mask, and that should protect your supply of N95 masks. And if you see somebody with one, you should be able to ask them, or it depends on your procedure, but if you're like handing them out at pharmacy, like some people are, then you have to be clear what somebody's doing, and they're either working in an area where they're at risk of TB, or they're doing swabs. Otherwise, they shouldn't have one. So there's general IPC, I'm going through the document, general procedures, then there's environmental controls, which you can come back to, which is all about spacing patients, and we can talk about that. But in terms of PPE itself, so key elements are standard precautions. It emphasizes this, which are the precautions that standard precautions are what we should be using all the time for all patients. Hand hygiene is number one. So the question is, to people, where is the virus? And like I say, it might be in the air for perhaps 1 to 2 meters around the patient. if they're coughing, so a symptomatic coughing patient. But other than that, it's on surfaces. Those surfaces are people's hands, and they're any environmental surface, any fomite basically. So that's where the virus is. So to get the virus onto you, unless you, like I said, within, you're close to a coughing patient, essentially it has to get onto your hands, and then it has to get from your hands to your eyes, nose, and mouth. And it could be anywhere. So the key is very frequent hand hygiene, because another key point is that it's very clear that asymptomatic people spread the virus, which is very, very important. So just to contrast that with Ebola, in Ebola, people with Ebola were sick. And so if you divided sick and healthy people, you could be very confident that when you send your healthy person in one direction, that might be to a ward or an outpatient clinic, that they would not be transmitting the virus, and that everybody in that area would be safe. And then you had a sick area where you had to have significant proportions. Not the case with COVID. Even though we are splitting patients by symptoms, it's inevitable that there will be people in your so-called clean side or your asymptomatic side who are able to transmit the virus. That includes patients and staff. And just as a sort of anecdote, I follow what's going on in the UK, because they're a month or two ahead of us. And they're seeing more patients. This is in hospital now. They're seeing more patients who caught the virus in the hospital than caught it outside. So somebody comes in, with a UTI or something, an old person, and then a week later they come back with severe COVID. And they're not, clearly they're not deliberately mixing patients with UTI with patients with respiratory symptoms. They're keeping them separate, and yet these people are still getting COVID. So it's very important to realize that on your so-called clean side, there will be virus. And so and the way to stop that is very, very frequent hand hygiene. I'll come to the questions later. Yeah. And that's the thing to get across. If I was to do a public information video, which I'd like to do, I would show pictures of where the virus is, and it's not in the air. It's on air, but it could be on anything anybody touches. So hand hygiene is key. Appropriate PPE, it emphasizes, and we discussed that a little bit. We can discuss in more detail. Patient placement, so that's important. That symptomatic and asymptomatic patients are separated, but that won't be the whole job. And so wherever a patient is right now, they need to be essentially socially distanced. So if you put symptomatic patients in a room, you don't know which ones have got COVID and which ones have got TB, and you really don't want your TB patient getting COVID. So even in your symptomatic side, you need patients socially distanced and wearing surgical masks. And in your clean side, where asymptomatic people go, you still need people to be socially distanced, because some of them will, at some point, there'll be people in there with virus. They're not wearing masks, but they're socially distanced. Appropriate use of antiseptics, disinfectants, and detergents. So that's essentially cleaning. Respiratory hygiene and cough etiquette. So I think people know what that is. I think most of the public even know what that is. So coughing into a tissue and discarding it, coughing into your elbow, not coughing into your hand, and then environmental cleaning. So those are the aspects of the things we should be doing anyway, which are particularly relevant to COVID. Okay, transmission-based precautions for COVID. Patient placement, we've kind of discussed. Hand hygiene, so the WHO have these 5 moments of hand hygiene. Personally, I find it a bit irritating, because there are really 2 moments of hand hygiene. Before you touch anything and after you touch anything, essentially, is the 2 moments of hand hygiene. The WHO have turned it into 5. But really, if you wash your hands before you touch anything, particularly a patient, or after you touch anything, particularly a patient, then that will work. So that's how I think of it. Frequent environmental cleaning. So general areas should be cleaned 2 to 3 times a day with appropriate detergent. Terminal cleaning, so that's when that's generally for inpatients. and dedicated equipment wherever possible. And then there's various other things about durations of isolation. Aerosol generating procedures we've discussed. In primary care, that would just be taking a swab. In other areas, if people are working not in primary care, then, or there are other things like chest physio or high flow nasal oxygen, which has been discouraged, bronchoscopy, intubation, those kind of things produce aerosols. Risk-prone procedures. Okay, let's go on. So there's some signage. So which you can take off of this. So COVID isolation area, and it emphasizes droplet and contact precautions. So in a COVID isolation area, which is really that, I would suggest that if you're dividing your patients by symptoms, in the symptomatic area, all persons perform hand hygiene and wear a surgical mask. The clinical staff, doctors, nurses, and others wear an apron and gloves as well, and eye protection. That's in, I would suggest that was anywhere you put, I think some of you are calling it cough clinic, should be wearing essentially all of that protection. And there are signs you can download. Emphasizes hand hygiene. It emphasizes washing your hands after you remove your gloves. So gloves are not a total protection. Gloves themselves are difficult to clean, so the idea of wearing gloves and using hand hygiene with gloves on is not a good idea. You should change your gloves and wash your hands, or hand sanitize. It gives you how to wash your hands, which I think a lot of people know, and it gives appropriate use of PPE. And there's a table which sets that out in quite a lot of detail. So you'll be dealing with, it's got clinical staff, non-clinical staff, such as admin and catering, non-clinical staff cleaners, who are a special group, patients with respiratory symptoms, and patients without respiratory symptoms. So that pretty much covers everybody. Just to go in brief, so clinical staff, non-sterile gloves, non-clinical staff coming into direct, okay, this is interesting. It says non-clinical staff, admin, catering, coming into distant contact with COVID-19 patients and contaminated surfaces, non-sterile gloves, change when leaving COVID area. I'm not convinced by that. It's pretty much the question that Claire asked. Look, some of these things are a matter of opinion, but an admin staff member sitting behind a desk coming into distant contact with a patient, personally, I don't think needs to wear gloves. I think they need to have very, very good hand hygiene. They need to have a bottle of some kind of hand sanitizer and keep washing their hands, because they're passing, if they're passing things between themselves and the patient, personally, I don't see how gloves are particularly helpful there. But there are some things that are slightly a matter of opinion. Cleaning staff should wear long rubber gloves, and never gloves for patients. There's no patients should never have gloves. Face masks we've pretty much covered. So we've covered for doctors and nurses. For admin staff, when within less than 1 meter of a patient, a surgical mask, and cleaning staff when within 1 meter of a patient, and then when it's patients, they wear a surgical mask when they're symptomatic. So I think that's clear. Aprons, again, for clinical staff, discard between patients. For admin staff when leaving a COVID area, and for cleaning staff after each work session, and patients never wear aprons. Face shields we've discussed. Clinical staff when they're with patients, and cleaning staff as well, it says, because they may get splashes and things when they're cleaning. Question that often comes up is reuse of equipment. So I'll probably just cover that because that gets asked all the time. And it's a slightly difficult one. So, well, I think you have to just think logically about reuse. So a surgical mask, if it's not wet, and not dirty will keep its integrity for the duration of, let's say, a shift, let's say 8 hours. So as long as you don't get it wet, get it dirty, then a surgical mask should do its job for duration of a shift, and then it should be thrown away. If you do get it visibly dirty or wet, then it should be changed. N95 mask is interesting because we're very used to using them in TB, and we're not used to using them in COVID. So in TB, the suggestion is, now I've looked at this evidence because I've worked in places where I have very few masks, and the evidence is that there is very little evidence. But the general thinking is that you could probably use one for a week if you take it off carefully, either hang it up or put it in a paper bag or something like that, and keep it dry and clean. You can probably use an N95 mask for a week, although nobody really knows. That's come across into this document that I'm reading, but nobody I've discussed it with agrees. Because with COVID, whereas with TB, the air is contaminated and you're stopping the droplets coming through. With COVID, you're expecting to get droplets of virus on your mask. So you're wearing it because you're doing an aerosol generating procedure, and therefore you're expecting someone to essentially cough onto your mask, and your mask therefore gets contaminated with virus. And so taking that off, hanging it up and putting it back on again, when you have to touch it with your hands, it's hard to not to touch it with your hands, doesn't seem very sensible. And the people I've discussed, other ID specialists, agree that if you're using an N95 mask, like say you're only using it for taking swabs, that you can keep the same one on between patients because you're not touching it and it's not touching them. But when you had 3 patients to do it at the same time, after those 3 patients, you should discard the N95 mask. That's what we all think. It's a little bit, like I say, that's not what it says in the document, but it makes a lot of sense. Different, like I say, different for TB because the mask itself isn't getting contaminated, and you don't get TB from touching a mask with your hands, and then whereas you do get COVID from touching a dirty mask with your hands. So that's an important point. We could discuss cotton masks in the community. This is a big issue which is being discussed at the highest of levels right now. At WHO, there's a lot of discussion about whether it might be sensible to tell the whole of the public, like the whole world basically, to wear a cotton mask. And nobody really knows if that's a good idea or not, but it might be coming through. So currently, it's not suggested that people walk around the streets to the shops with a mask on, but that might change, and nobody really knows. Okay, so there's a whole document on extended use, and I think I've discussed face masks. Other things basically are discarded when they're contaminated, but goggles you should be able to decontaminate things like goggles. It covers donning and doffing. I think it's best to watch that on a video. Taking off is really all about the order that you take things off, and there's debate about that as ever, as with just about everything. But putting on, it's essentially says wash your hands and put your apron on, put your face shield on, whether that's an N95 or surgical mask, then your visor or goggles, and then your gloves. That's putting on. And taking off, it suggests wash your hands, take your gown or apron off, then your visor. Does it say that? Hang on, it doesn't sound right. No, it says wash your hands, take your gloves off, then your apron, then your visor. I'm a little bit dubious about that myself. And then lastly, your respirator. The reason I'm dubious about it is because during Ebola, I think this is how some people got infected. Firstly, I think the visor should be the last thing to come off because I think your eyes are very vulnerable. But taking off your gloves and then taking off your apron, rather than the other way around, I think it's better to take your apron off, then your gloves, because otherwise you contaminate your hands immediately by you've taken your gloves off, and then you using your clean hands to take off your apron, which is dirty, and therefore you immediately contaminate your hands. If you take your apron off with your gloves on, then take your gloves off, then you're not contaminating your hands quite so much. It's just, maybe it's a moot point. As long as you're washing your hands between each step, that should be okay, because you can decontaminate between each step, but that's just something to be mindful of. Then the document tells you how much hand rub you're going to need, and in terms of hand rub, obviously depends what you've got available to you, but it's very easy to make up hand disinfectant with bleach, which you can buy as an essential item. And this even has it shows you how to make it up. For some reason,
are you at the end of the document? Perhaps we can drop.
Do you want me to stop? Do you want me to stop?
Maybe because of time. I think there are about 15, 16 questions.
Okay, cool, great. Let's go to questions. Yeah.
Better feel for the document, and if they had any questions, they'd be able to be prompted enough.
Fine, no problem.
So, do you have the Q&A in front of you? In terms of, I've told people on the group that the video recording will be available with the document on a website. Sure. They can pick it up. So you just email it to me, and then I'll make it available. So you've got the Q&A you've got in front of you.
Is it chats? Is it under the chats?
No, there's a Q&A. If you look, scroll below, it's got the red 16 on it. I think you just click on it. Or you want me to read it? Perhaps I can read it if you.
Sorry, it might be to do with raise hand. It might be because I'm on a phone that it's not
right.
Quite.
Let me.
Q&A. I've got it. No, I've got it.
You've got it. All right.
Okay. So should I start at the top?
Yep. Start at the top and see if you can just go through it, and if there's something repeated, you can just skip it.
So are we into the really infective period at that stage? I think you're talking about the epidemiology, I assume. So where are we in the epidemiology? I think, you look at the curve. We're all, I mean, my view is that there's essentially been a middle class epidemic and a non-middle class epidemic. And the middle class epidemic maybe is under control. So what I mean by that is the people who flew in on planes bringing the virus in the first place. I'm wondering if that epidemic is under control with the lockdown. Then you would expect, in South African circumstances, you'd expect it to be transmitted from those more wealthy areas into less wealthy areas, probably from workers who work in one place and live in the other. We're all sitting here waiting for this deluge of patients, and currently it's just not happening. Where I am in Helen Joseph, we haven't tested a single patient positive yet. Although we're working 16 hours a day getting everything ready. So, I mean, I think just watch this space and follow the curve. I still think we're going to get a lot of patients, but it's taking a little bit longer to kick off than I was expecting. That's what I can say.
Well,
is there any
the numbers?
Sorry?
People need to just watch the curve.
Yeah, watch the curve. Is there any role for the cloth mask in breaking transmission when worn by the general population? I think I briefly covered that. Nobody really knows. There's a lot of discussion. There could be an announcement in the next day or so suggesting that people in the general population wear cloth masks. So the answer is nobody knows. There's a suggestion that possibly one of the reasons that Asian countries did better was that the staff tend to wear masks. Populations tend to wear masks, but they did a lot of other things differently. So nobody's really sure. Some people think that if we do it, then people will do less hand hygiene and it'll be detrimental. The answer is nobody really knows. Do we have standard screening questions we're using around the country for COVID? As we haven't been informed as such at Lillian Ngoyi. Okay.
Answer that, but
that's a good question. Sorry?
Let me just quickly answer that. I think it's about what their information is. I think that the managers, Dr. Ruiz, Dr. Patha, has actually been given a document, a plan, as well as other documents. So please talk to him. In fact, Lillian Ngoyi is where we've told people to get documents out to all of the districts. So Dr. Aki, Dr. Petkova, and Dr. yeah, Petkova and Ruiz need to help you. All right.
Sure. I think I'll just tell you briefly what we're doing and what we put in our documents and videos, because it will just take half a second.
Go ahead.
So we're asking patients at the front door, do you have cough, fever, shortness of breath, or sore throat for less than 14 days? Or if you've got a chronic cough, has that cough significantly worsened within 14 days? That's what we're asking. And that's the basic screen, which can be done very basically. And then if you're symptom positive, you can then go on to work out if someone is actually a PUI based on other factors. So that's what we're using.
Yeah, very similar to ours.
Yeah.
Good.
It's the difference between PPE and Ebola. So yeah, probably not something to go into in great detail. Ebola was contact driven, and people were much more terrified of getting it, I think, is one of the reasons. So yes, we wore full body covering. We didn't let the Ebola get onto our skin at any time. But in theory, you know, it would have been the same because it was essentially contact precautions, but we wore much more stringent PPE in Ebola. I think partly because we were more terrified of getting it than because it was absolutely necessary.
But apart from the terror, is the expectation much has been put out in the guideline?
Yeah.
For COVID. Okay, thanks.
If N95 is not available, is it safe to wear double? I wouldn't do that. Double surgical mask during. I don't think that's safe. I don't think anyone should be doing anything that's unsafe, personally. So no, I would not recommend a double surgical mask. I would recommend not doing the swab. Swabs are not the be all and end all. I mean, it's not going to change the world. I just don't. My advice is don't do anything that's unsafe. It's just don't do it. So interesting info around N95 for swabs. Canadian guidelines have been adamant so far about not needing N95 for swabs. Just a regular surgical mask is considered safe. Okay. Again, there's very little data to back up any of these discussions. If you talk to people like Shaheen Mehta, who are having WHO level conversations every day, countries are making slightly different decisions. Our decision is very much to use N95s. Another country may make a different decision. There's no, this is not backed up by absolutely robust evidence. I think most people think that Canadian decision is not a good one.
Is WHO guidelines saying yes for swabs?
I think it does. I'm not sure. I'd have to check. Regardless of what it says, the South African one says you do. So.
Okay, I think maybe some of the people outside South Africa, so might be the question.
Okay.
Okay.
Yeah. I mean, yeah, I wouldn't do it, but there you go. Are we underestimating the aerial transmission aerobiology of COVID? Good question, Michelle. To be honest, I had so much to read recently. I haven't been able to read every thread that's been sent my way. The answer is maybe. I think some people think that this paradigm, which I described at the beginning, of droplet versus airborne is too simplistic, and that there may be, life isn't quite that simple, and that there may be some aero transmission of the virus. So again, limited evidence. Some people think there might be. It doesn't seem to be a major route. Is all I can say. Maybe it's a very small route. If it is, it seems to be a minor route. Otherwise, we'd be seeing much more transmission for people not wearing. Yeah.
Something brought to my attention. I'm not sure what the evidence is. I've not had a look at it, but he said that there's a claim in the US that the virus might be spread with someone within a meter, even by talking and laughing. Do you think that's true? True.
I think within a meter, that's probably reasonable. Yeah. I think that might well be the case, which is really the reason for wearing surgical masks within a meter of someone. It's partly in case they cough on you, but I think people are thinking it's a reasonable precaution in case, like I said, the paradigm is a little bit more complex than has been suggested, and that talking and laughing is enough to produce some kind of infectious material. So yeah, I think people think that probably is the case.
So Tom, the next question is asking about these masks for the public, cotton masks. Your view
Okay.
on it?
I was listening to other people's views. Some people thought, look, it can't do any harm. Other people thought people will get a false sense of security. I think maybe that this might be recommended soon. You know, because people were like, well, you can still push hand hygiene as well as masks.
Yeah,
So, it's unlikely to do any harm. So I think this might be pushed quite quickly.
But I also wonder about people's mental health. I mean, people are thinking of the physical health, but not the mental health. And that people, it might be a false sense of security, but it is a better sense of security. And that is their mental health. So I think they're pushing it, like you said, is a good idea. Anyway, we're pushing a campaign to push that idea of getting people, especially in our context. So thanks for that comment.
Yeah. Next. Okay, so this is the same question about 2 pairs of surgical masks. Should health workers refuse to take swabs if not provided? I would, Mimi. I would refuse. It's not the end of the world. Certainly, if someone's going home to self-isolate, this is a personal view, but I don't think anyone should be putting themselves in harm's way. And I would personally refuse to do it, and I don't think anyone could criticize you for that. That's a personal view. Because particularly if someone's going home to self-isolate with a mask on, and particularly if they can self-isolate because they live in a house with multiple bedrooms, then knowing they've got COVID or not isn't the biggest thing in the world. So number one rule: protect yourself, in my opinion. I think I answered the question about reusing N95 masks. I don't think I think you can use them if you're doing 3 patients or 5 patients in a row, but should discard them after that. Do we know how long it survives on surfaces? Yes, there's a very good article. In the New England Journal of Medicine, a letter where someone actually tested this, and it's different for different surfaces, and it's not a question of it just being there and then dying. There's a curve, and it's on a log scale. It drops linearly, so it basically has a half-life on different surfaces. It doesn't live very long on copper. Lives a long time on plastic and other metals. It doesn't live so long on cardboard. So I would suggest going to the New England Journal of Medicine COVID site and looking that up for a bit more detail. If wearing gloves, maybe less likely to touch face. Is washing gloved hands regularly an option? It's not recommended. I understand about not touching your face with gloves on. That may help, but the dogma is that it's hard to wash a gloved hand very well.
And I mean, you're touching different patients, so that glove is going to transmit it.
Absolutely. You must change gloves between patients.
Yes.
Yeah. You can't wash gloves and move from patient to patient. Definitely not. No, that's a definite no-no. Okay. Hi, Doc. What is the risk of getting COVID in those? Concomitantly infected with TB? Are the anatomical changes that occur in TB make you more susceptible to COVID? Again, nobody really knows, but I don't think you might be, because you're more immunosuppressed, more likely to get it. I think you're much more likely to die from it if you've got TB. I think most people would think that was reasonable. We don't have data yet, but most comorbidities seem to make COVID worse, and so I don't think you can say someone's more likely to get it if they've got TB, but I think you'd be very, very clear that if they get it, they're more likely to die. And that's one of the reasons for example, when you've got what I think you're calling a chest clinic, your symptomatic patients, that one's got COVID and one's got TB, and that TB person is the most vulnerable person in the clinic right now, and they desperately need to be protected from the COVID person sitting next to them. How are we supposed to clean decontaminate rooms when the swabs are taken, and when? So, Mimi, that is in the document, which I'll show you. There's basically how to clean rooms and things.
Do you think each swab? That's
sorry.
Do you think it should be decontaminated after each swab?
After each swab, that's a good question, isn't it? It's a good question.
Yeah. I mean, it would become very onerous if you are having lots of
Very
colleagues.
onerous. Yeah, it's clear that if you, although you're not changing your N95 mask, you should change your own gloves and apron. Fully decontaminating a room between each person is going to be difficult.
Yeah.
It depends a little bit what your setup is.
It does make sense if, in a sense, there's coughing.
It makes sense to do it because they're coughing into the room. It does make sense, and I think a dogmatic answer would be yes.
Yeah.
But it's going to be very difficult to do.
I think the easier thing to do is to actually not have that room have anything.
Yeah,
that's
absolutely.
So
just a chair.
Floor. Yeah, it's a clear room with nothing else in it. You just
Absolutely.
take what you need into it and you use that space. And so it's very unlikely anyone's going to touch the floor, but then again, they could walk out with it under their shoe. So, but that's, I think, as good as it gets. And that might be the easiest thing to do is put on, I don't know whether you think that's a recommended.
Yeah,
these shoe,
definitely
covers.
should be a sparse room with just a chair and nothing else.
Do they need the chair? I mean, couldn't they stand and do it?
They can stand up, yeah, absolutely.
Yeah. And then what about these covers to your shoe? Do you think that's necessary in that space?
Nobody thinks they are. It's not in the guideline, it says not.
Okay.
So, again, could kind of make sense, but...
especially if it's droplet on the ground.
Yeah, I know, it makes sense. Understand that it makes sense.
Carry it out with your shoe and
sure.
walk your carpets and roll on your carpet.
Yeah, I understand that makes sense. If you had them, I would use them.
Yeah.
Guideline doesn't suggest so, but I do understand that does make some sense.
Right. I'll send this out to Bongi, so Bongani, don't worry. I've sent a message to say the recording is available.
Sure. Actually, that's not McDonald. That suggestion that actually doesn't refer to wearing 2 pairs of gloves. There's nowhere in the document that says wear 2 pairs of gloves. During Ebola, in Ebola, we wore 2 pairs of gloves. The first thing we did was cleaned ourselves up to our elbows with strong bleach, and then took off the outside pair of gloves. But there's nothing in here which is just using 2 pairs of gloves. So
would you recommend it?
I don't think it's necessary. I don't think it's necessary.
All right.
I don't see a value in that now.
All right.
Can you comment on waiting time following an intubation for virus to settle before a person can go into the room? So you're talking about essentially, actually intubating or taking a swab?
I think it's about waiting for an isolation space where you're intubating. I think, and then to reuse it, perhaps.
I don't know about intubation. You're rarely going to do that. You're rarely going to reuse the room very quickly if you're actually intubating a patient. I don't know if anyone on this call is intubating.
Well, I think we wondered about that happening as an emergency in the primary care.
Yeah, maybe as an emergency, then it'll be very rare. So I think you.
Sure. So that's fine.
Leave the room for a little while.
I think people should, they just need to have those kind of isolation spaces, which we've also talked about being done in the facilities, but let's hope they look at something. All right.
Yeah. Do we need to stick to the case definition and call the NIC before we test? I think you do need to stick to the case definition, because I'm not sure testing, because I'm not convinced that testing is always that important if someone's going home to self-isolate for 14 days. But the case definition is, so either you're an inpatient with SARI, severe acute respiratory illness, or you're an outpatient with who's not severe, doesn't have SARI, and has got travel history, contact history, or has worked in a facility.
So technically, the question would be, and I think if I can just interject there, if the kind of requirement would be is if there is a patient right now that's been identified in any clinic, the response to the department is to shut the entire clinic down. I'm not sure. That was a staff member, but if a patient pops around and they think it is, it's defined that the person has it, then only we treat the patient who comes after that. as if they've got COVID. So I'm just trying to think, are we waiting for one in a facility to then say, right now we test?
No, you have to be a staff member. I mean, to be tested, you need to be a staff member caring for patients who in a
just an
facility.
identified patient.
Not just any patient that's been in any facility with COVID right now.
Right.
That's the idea. The idea of that is to pick up people who are at highest risk because they're staff members in a unit looking after patients.
Now, is it current because the Department of Health has actually started sending out these units and saying, please send to test from staff members?
Right.
So the question is that at the moment they're complaining there's not enough being sent to them.
Right. I haven't been part of that conversation. I'm sorry, I haven't been part of that conversation. I would just say what I do think is that following my comments about asymptomatic people, that I think, to me, if I was in charge, I would be prioritizing staff testing. I would be prioritizing asymptomatic staff testing.
Yeah.
Symptomatic staff should be at home. That's less important in a way. Although maybe you could argue you can get them back to work if they're test negative. But symptomatic staff shouldn't be there. Asymptomatic staff, are at risk of being infected because they're in contact with more people than everyone else in the lockdown, and asymptomatic staff could cause havoc. So if I was in charge, I would be like staff symptomatic at home, asymptomatic, I would be prioritizing testing.
How would you do that? Just as a question,
look,
would you do that weekly or?
Yeah, I would. If you had the capacity, I would be testing asymptomatic stuff weekly. That would be my call. I'm not in charge. It's not my decision.
First contact, in other words, who routinely are within a meter of a patient.
Look, I think, to be honest, staff, by definition, are not, in the lockdown as much. They're using taxis, like, other things often, and they're in a clinic with lots of people. So, certainly clinical staff, and I would, because they're the ones who can then transmit it on more. But it's up for debate. But I would be testing staff a lot.
All right, good, useful, thanks.
Any evidence supporting chloroquine prophylaxis? Nil, absolutely none. There's a trial which is planned. You can't get chloroquine anyway, and if you do, you might be taking it from someone who needs it for their rheumatoid arthritis. So the answer is no. If taking a swab is an aerosol procedure and a healthcare worker is testing a row of patients in the same room, are the next patients not exposed? So I think we discussed that. We're suggesting a
isolation room.
And sure, I mean, you want a ventilated space, a bit like TB. It's the same question for TB essentially. You want your room to be similar to a sputum collection place with ventilation, and sure, a little bit of time between patients would be sensible. Would you advocate open air swab? Yes, absolutely. Open air swabbing areas, 100%. If you can do it outside, do it outside.
That's very useful.
Absolutely. Yeah. It's the same as TB. Yeah. No, if you want someone as far away from anyone as possible with open air and the wind blowing as much as you can to dilute the virus. Absolutely.
Good. Wonderful.
What about hair covering protection? Is this part of PPE? No. It's clearly stated in the document that hair covering is not part of PPE because there's no evidence that it helps.
People feel a bit obsessed. Oh, I need to go home and wash my entire body. Do you think that some people that's a bit neurotic?
I think, and I think it makes some sense particularly if you're doing aerosol generating procedures, that you could become contaminated. And there's these suggestions about keeping yourself healthy is that you have a shower as soon as you get home before going to your family. I think that makes a lot of sense. I'm doing something similar. Change your clothes at work. If you have a shower at work, then great. But often people don't have it. That these sort of sensible precautions make sense to me. I don't think there's anything wrong with using hair covering, but it's not in the document. Okay,
great. So the last one is from Michelle.
Okay, is the test geared for a screening test in terms of sensitivity, specificity, i.e. asymptomatic staff? So what you're really saying is how sensitive is the test in asymptomatic people? There's various numbers that are given. It's difficult to know because you don't have there isn't a gold standard as such. It's about the amount of virus that is around, and obviously about how well you take the swab and everything. So no, it's not 100% sensitive, but in an asymptomatic person, but it's all we have, and nobody can tell you the exact sensitivity because there's no real actual gold standard. That is the gold standard. PCRs are intrinsically sensitive, usually less specific. So unfortunately, that's all we've got. I guess what you're implying is if it's negative, can the person come back to work? That's a slightly difficult one. And an asymptomatic person, then yes, otherwise all asymptomatic people would be off work the whole time. Can a symptomatic person come back to work with a negative swab? The suggestion is, the documents say they can. I'm a little bit cautious about that suggestion, because if you're coughing and you're negative, if that is a false negative, that's really a problem. So the guideline says you can have standard precautions. So basically, you shouldn't come to work when you're coughing anyway. So the session is go back to standard precautions if you have a negative test. Okay. Safe disposal, that's a good question for you.
No, I think it's asking about safe disposal generally. I mean, I think everyone needs to treat everything that they touch or use as PPE, as medical waste that you need to manage. So not just in the normal bin. And I think you must make sure that's available and managed properly by the cleaners.
Yeah. Scenario: employee in a company tests positive for COVID. Other than follow up on close contacts, is there any reason to close a business? And I don't believe so. Not to close a business, I think.
Yeah, the decontamination, I think, is about, well, you need to make sure that the entire company's practice is reviewed, I imagine, of safety in the workplace.
Yeah.
So if that needs decontamination of some places, that might be an option.
Absolutely, I don't believe so. Is there a role for massive spraying? No, the suggestion is absolutely not. The South African guideline says that's not likely to be useful.
So thank you. I think that there was one in a question: is there any place for rapid COVID tests? I think there's a thought about that. Any thoughts on it?
The antibody test, the rapid test.
The rapid test. I'm not sure if it's ideal. I think might be referring to the rapid test. Rapid coming out.
The rapid test I'm aware of is an antibody test, which shows you, which is not a good diagnostic test at all. It's a test to see if you've had it. And that, I think, can be useful in getting people back to work. If you can be confirmed to have had it, and we assume that you're therefore immune, although that's not even 100% known. But this rapid test that we keep hearing about is for antibodies, and it's not a good diagnostic test. It's a test for
so perhaps that's, as you say, a test to come, to get people back to work, maybe.
That can be useful going forward. So we start to get the country going again, because positives can go back to work, but doesn't appear to be a diagnostic test now.
No. And the seroconversion post-testing?
So what about that?
I'm trying to understand.
I'm not sure what that really is referring to. I mean, clearly it takes a bit of time to produce your antibodies, which is why it's not a good diagnostic test. I'm not sure exactly how long it takes. Probably a week or so.
Well, we're on the hour, 4 minutes after the hour. So thank you very much. I'm going to just leave it at that. I think the one last question, gene expert for diagnostic.
So the cartridge has been made and it's been approved. And I saw, I don't know what's going on with these vans that we keep seeing in the press, but the picture of them had gene expert machines on the inside. So that suggests that those cartridges are in the country, but I only know that from what I've seen in the press. They definitely exist.
Brenda has raised an interesting question. Tested negative today and after 14 days changed to positive. I'm not sure I understand that, but
someone can be negative early in the disease, or they can become infected after the negative test. So I think be negative and positive after 14 days, either because you were early in the disease or because you became infected in that 14 days. So.
Right. Thank you very much, Tom. I think it was very useful. I'm sure people got lots of value out of this. I just want to remind everyone, please, we'll send this document out with the link to the video, so you'll have it to look at. The other videos that are posted here, we'll try and post some videos that will give you more education on PPE. I want to remind people, I've sent it out in the group, that in fact Sama has indicated that this is not something that you should just take lightly and just do, and that your employer needs to be very aware of it, and that means your manager must be shown the fact that you need to be protected, and if not protected, you can actually refuse to provide services. And I think that will shake them up, because there is a great deal of problems in the clinic system. I'm very fortunate. I'm going to meet Tom a little later. We're going to go out to the clinic, one clinic, to just get an idea of how we are going to do things, or how we are doing things, and share some of the challenges. And Tom has been offered to assist in the primary care setting to help us think through how we're doing things and support us. So I'm very grateful for Tom's contribution today. I'm sure we're going to see him and others, you know, in the space talking about COVID. And being the sort of, you know, the topic of the day, I imagine we're going to have these CPD meetings every week. So with that, I want to say to all of you, thank you very much for attending. Please spread the word that there's this regular weekly meeting on a Friday, 8 to 9. It's part of the Department of Family Medicine in the Johannesburg Health District. And we want to make sure that you keep in touch as clinicians. This is Shabir Musa, the professor in family medicine. Sorry, I didn't introduce myself, but I hope to see you all next week. Thank you all. Go well. Keep safe.
Okay, thanks. Bye.
Bye-bye.